Bom dia, olá! Hoje o cafezinho de segunda-feira está mais do que especial, porque eu estou aqui em Istambul, na Turquia. Acabamos de participar da primeira conferência internacional sobre o gerenciamento da escoliose. E hoje aqui do meu lado eu tenho uma participação incrível da Esther De Rue. Ela é da Holanda e ela é especialista em fisioterapia pediátrica e neuromuscular também, e ela vai nos dizer um pouco sobre a importância da junção dos conhecimentos da escoliose com a questão neuromuscular. Ela fez uma belíssima apresentação que vale a pena, a gente vai falar dela para vocês. Esther, how are you?
Very well, thank you. I'm very happy to be sharing my
coffee
with you.
Okay.
Because I have watched you many times with your coffee talks and now I'm part of it, so that's fantastic.
Yes.
Thank you for inviting me.
Oh, thank you for you to be here with me.
So I take one little sip.
Yeah. So I want you, my dear, that you talk about a little bit maybe about the importance of the knowledge about a little thing maybe about your practice about scoliosis, neuromuscular with the babies, with the child.
Yes.
Okay.
So the neuromuscular scoliosis is quite different and possibly more difficult to treat than the idiopathic scoliosis because we have the added problem of the spasticity or that a child is completely low tone. So it's a completely different way of treating, and the scoliosis can really become aggressive during puberty also. So like the idiopathic, we need to pay attention to help them as much as possible. When I was busy preparing the lecture for this conference, I looked at all the research, and so in short I will tell you what I learned and what I would like to share with you. I think one of the things is if you see an asymmetric child, preferably a baby, be aware that this child could have a problem with contractures only, which can be total in the body, not only a scoliosis, but that child could also have a hemivertebra, so we would need to take an x-ray. But if that is not the case, this child might be a child that will develop cerebral palsy, and the sooner you start treating them, the better. So if you have this child and you think, whoa, this could be a child that possibly gets cerebral palsy. I see strange movements, I feel stiffness. The things I would say that are really important to do are, first of all, position a lot, change position. Many of these children are in bed on their back, and in the daytime they're in a chair, and we put cushions everywhere to keep them straight, and that is all. So that's 2 positions in 24 hours. These children need to be positioned regularly on their stomach and on their side, especially for their lungs. So positioning, and this is something you could teach the parents, that they need to give their child the chance to change position, because when we are in bed, we often roll from left to the right. When we are in a chair, we stand up, we shift to the left, we shift to the right, and these children cannot do that, so we have to do it for them. That is one thing. The other thing is we need to, in whatever manner, try to keep the pelvis straight. So if you have an oblique pelvis, this child is starting to lean sideways, make sure that pelvic is straight, because then the spine can go up straight, and otherwise you will make the scoliosis that is developing worse. If the child is good enough and can stand, please do this as much as possible, because even if you are just helping them get up from a chair and they stand, wait, get weight bearing, because that is very important for their bones. They need to be on their feet as much as possible. I think they are the big differences between treating an idiopathic scoliosis, the positioning, the weight bearing, and having a lot of looking and checking the lungs. Because if a child, once they go into this terrible curve, the lung cannot develop, and of course the stomach doesn't have enough problems, so these children often also get internal problems with organs, especially the lungs. The other thing that I heard the surgeon say also, but I'd already read about, the difference for them when they're operating is that their spines of a child or an older child they need to operate, compared to the idiopathic children that they operate, the spine is much stiffer, and they will actually make, they will delay their operation if the spine is still mobile. So I would love every child with a CP, every child with a CP has a chance to get a scoliosis. I would love you to all mobilize, just keep those spinal joints mobile. Just manipulate a little bit and shake them a little bit and go through the whole spine, because that also relaxes the spasticity, and then you can do more with your NDT program. But just mobilizing that total spine every time, teaching that to the parents, could probably help delay surgery, because most of these children at a certain point need surgery, and the older they get it, the better, because a young child that is operated on, the surgeons have the problem that they sometimes have to restrict the growth, and then the scoliosis becomes worse in the long run, and they have to be operated on again and again.
Okay.
So try to mobilize that spine, and of course all the joints, because the other problem that the CP children often have is that because they are always in a chair, they get many contractures in flexion, and the contracture of their knee is especially important for the spine. So the more contracted the knee is, the more the scoliosis will be difficult for the surgeon to get back. So when a surgeon has repositioned the spine, we still have all these contractures that make it more difficult. So I would say the idea is for pediatric physio, is to try to stop the curve progressing, but realizing you won't be able to stop it, by keeping the children mobile, weight bearing, and doing your whole program, and for the parents and you to change their position much more often. Go on that stomach, go on the sides. I think for the general health of these children, we need this sort of programming.
Very, very good. Thank you so much for
You're welcome,
your
Patricia.
important informations, and I really believe that we will help so many people there in Brazil and many in other countries too.
Because the method Schroed and CS that you have been promoting in Brazil is often not suited for these children. It is too difficult. Sometimes you have some experience with adults.
Yes.
It can be done, but you need somebody that is really able to understand what they need to do. And for many of our young children, they don't understand. So one of the other things I did not mention is what I love doing with children in general is using PNF. Because even if a child is in a cast, you can still do your PNF and you are strengthening them. And they need to be mobile, they need to be strong, especially their upper limbs.
Yes.
Because they need their arms to move themselves around. And so making sure the arms are strong, and that's fun with PNF. PNF is play.
Yeah.
Kids love it. So I combine methods. I use little bits of Voita, I use little bits of the Bovath, I use PNF, I use the mobilizing techniques when I treat children, because I try to get the best of all the little things that I can do. But even if you have not had all this training, you can still do this. You can mobilize very lightly, put these children on their feet and let them do something. Play a game with them while they're on their feet. Make it fun to be on the feet. And make sure they're in many postures. I think that's the, and look after those lungs. And of course, one thing I forgot.
Yeah.
I am specialized in the taping. And people that are interested can look that up on Facebook. I have a Facebook page about elastic therapeutic taping, not only in pediatrics but also for head, neck and orofacial disorders. And then we talk about all the different types of tapes that we can use in the pediatric patient and in the adult patient. And the tape I use most, and I think is very good for these children, is the diaphragm tape. Because we have research showing that if you tape on the ribs on top of the diaphragm, that the diaphragm muscle will keep its strength. They did research on patients that were on the incubators, and they did one lung, because then when patients are on the incubator, their diaphragm becomes atrophic. So they did tape on one lung and didn't do tape on the other side. So the patient was his control, and they found that the muscle was completely good on the side they had taped and was atrophic on the other side. So there's enough proof that tape works, and it's especially good for people with lung problems or a weak diaphragm or a diaphragm that cannot work properly because of the scoliosis. So I love using the tape for the diaphragm. And I think that's, and you can read all about that online also, and maybe I can send you some information that you could maybe translate, because I have written a little article about this, not specifically for scoliosis, but maybe I could do that and send it to you, and then we could, but you need to translate then.
Marvelous.
New idea.
Yeah.
So maybe that's a good idea.
Okay.
Yeah. Okay.
Thank you so much.
It was my pleasure.
Yes,
Thank you. It's always nice to meet Patricia.
Yes.
We met at the first CS course in 2011.
Yeah.
And we've been in contact since.
Yes.
Yeah.
Okay. So, não foi especial esse cafezinho? Bye bye. Até o nosso próximo. Tchau.
Ciao.